Thank you so much. So this is Ken Crandall, and I am calling the December 3rd meeting of the Seneca Healthcare District Board together at 3:01. Roll call. Dr. Walls, are you present?
Yes.
Kristen Montgomery?
Here.
Hey, Kristen. Rich?
Here.
And Jerry Nielsen, have you joined us yet?
Jerry just texted me and says she's having technical issues. She's trying to reboot and get in again.
Okay.
So it may be a few minutes.
Okay, thank you for that, Kristen.
Mhm.
Okay. With that said, it's time for the Pledge of Allegiance. So I'd ask you all to join me in saying the Pledge of Allegiance. I will start it now. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible,
with liberty and justice for all.
Thank you so much. And that takes us to item number 3 on our agenda, the public comment period. So I'm asking now if you are a member of the public and you would like to address the board, it's your opportunity to do so. We limit public comments to 3 minutes. And TK, I'm assuming you will let me know. Comments from the members of the public? Well, hearing none, I will move on to agenda item number 5, which is approval of the meeting minutes from October 29th meeting. So I look for a motion to approve the minutes from October 29th, our regular scheduled meeting then.
I'll make a motion. This is Kristen.
Okay, and a second?
I'll second. This is Dr. Walls.
Walls, okay. Okay, Rich, your vote?
Aye.
Okay, and I will vote aye. Dr. Walls,
Aye.
Kristen,
Aye.
and I'm going to ask Jerry, make sure Jerry's not yet in. Jerry, are you in?
I'm here now.
Okay, did you, we were voting on the minutes from the October 29th meeting, and it's your vote.
I'll vote aye.
Okay, thank you very much. And next, item number 6 on our agenda is the med staff report. I'm not sure if there's someone to speak to that. Joanne, I know you sent that out. Wondering who will speak to that, or if there's a need. Dr. Cooper, or somebody from med staff anyone like to speak to this? Any questions from the board?
Are we going to have a member of the medical staff here for the meeting?
Ken, I'm going to see if I can assist Dr. Cooper and unmute his line. I'm going to send
Okay.
a request to him.
We'll
Yeah.
hold for just a minute.
There, I saw it. Okay, can you hear me now?
You're a little bit echoey, but I can hear you.
Okay. Sorry, we were having problems with the link and a few things, so.
I'm wondering if you're on a speaker or if you are not.
Oh, you know what? Yeah, I think I'm gonna speak. Can you hear me better now?
That's much better.
Okay.
Thank you.
And so,
We have go ahead.
I'm sorry, did you have a question for me?
Well, we're at the med staff report, and I asked the board if it was submitted by Joanne. I'm wondering if there are any questions from the board or if there's a report from you, Dr. Cooper.
Well, from the last med staff, I don't think we have much to report from that. However, you're familiar with the situation as of yesterday.
Yes.
And we're in the process of developing, I think we basically have them in place, some pathways for treatment of COVID patients in the hospital.
Okay. Question?
And I'm going to talk to Sean about if we need to have any of these medicines stockpiled. Currently, I don't think with our current need, we have a need to stockpile any of these medicines, but I'm going to talk to Sean about future needs.
Okay. Thank you for sharing that. Question?
And what medicines are they?
Well, there's 3 medicines that are right now used for the COVID. One is the monoclonal antibodies, and that's the question that I have. That's the main one. They're not recommending or advising against that one. They're kind of leaving it up to the doctors. As far as remdesivir, they're saying, no, don't give it in any circumstance. Basically, the World Health Organization. And these are some pathways that Adventist Health System has gone through, and they had a big panel with doctors and pharmacists and all that. They're not recommending remdesivir. They're not recommending the baricitinib, which is had a current FDA recommendation, but the subcommittees there are not recommending it be given. So the only one of question is the monoclonal antibodies. And so these all, the remdesivir is on the algorithm that they have, but they're not recommending to give it. I think that they were not trying to tie the hands of the doctors and saying they couldn't give it, but it wasn't recommended. So, and I need to talk to Sean about, I don't even know what the availability of the monoclonal antibodies are, if we could get those. And I think in the current state that we're in, we wouldn't give our current residents the monoclonal antibodies. And so that's what I need to talk to Sean about maybe future cases, whether or not we want to have that on hand.
Okay.
Right. Thank you.
Additional questions?
I was just curious if they've started any treatment so far on positives or.
I'm ordering labs, but right now the treatment is kind of based on their labs and findings. So you don't just necessarily, just like if we have a person in the community, it's mainly they're being sequestered and things like that. And so I don't know, I think Dr. Walls had one patient that started desatting with their oxygen saturation. And I don't know if he initiated any treatment with that person or not. I did give Dr. Walls the algorithms last night, so I didn't know if he implemented any of those with his patient. But
Ken, I'll just address that real quick. The only thing I've used so far is oxygen if the saturations drop below 90%. And that's not unique to COVID patients. It's anybody with a pulmonary infection.
Right.
Okay. Well, thank you, Dr. Cooper. I'm assuming most board members have had an opportunity to see the report submitted by Joanne Matlock on the 18th of November. As there's really no action items on the report, but I would like a motion to just accept the report as submitted by Joanne again on the 18th of November.
I'll make the motion.
Was that you, Dr. Walls?
Yes, I'm sorry.
That's fine. Okay, Dr. Walls makes the motion. Can I have a second for that?
Second.
Okay. Jerry, how your vote?
Aye.
Kristen
Aye.
and Rich
Aye.
and Dr. Walls,
Aye.
and I'll vote aye as well. Thank you very much, Dr. Cooper. Item number 7 is our financial report. So we're looking to Steve to fill us in.
Okay. So in tab C is the financial report for October. We got the information out to you quite a bit earlier than we normally do. So we hope that you've all have had some time to look at it. Did meet with Rich Rydell and Sean, Treasurer's meeting yesterday, and we've gone through this. There's not much here. We performed to our budgeted expectations, which is still below historical utilization and operational results. So I guess I really don't want to go into the details unless there's some questions.
Questions from the board?
I don't have any. Thank you, Steve.
Others? Okay. Hearing none. I ask for, hang on just a second. A motion to accept the financial report for the month of October 2020.
So moved.
Rich moved. Okay, second.
I'll second. Jerry.
Jerry. Dr. Walls, your vote.
Aye.
And Kristen
Aye.
and Jerry
Aye.
and Rich,
Aye.
and I'll vote aye as well. Thank you very much. Moving right along, we have the HRG contract renewal, and I'm assuming that Sean would want to speak to that.
Going to defer to Steve. Steve, can you provide an update to HRG?
Okay.
Yeah, so we presented the contract to you all last month, and a couple comments came up, and so we pulled it back. I did take the contract back to them, got some language cleaned up, and to our benefit, we cleaned up the grammatical language that was brought in there, and then we're under tab D now. Very last page is confirmation that there is no interface between Evident and the new proposed product that they'll use for our billing clearinghouse, Quadex, versus what we use now, Change. And that we also confirmed with our internal IT that there's not a current interface between CPSI, Evident, and Change. So bottom line is that our understanding and what's being represented to us by HRG is there will be no transitional cost and ongoing maintenance. So the contract is the contract. So questions, comments, concerns?
This is Jerry. I appreciate that, Steve. Thank you very much. That makes me feel a lot better.
Yep. Yeah.
Other comments?
No.
Okay. Motion to approve the contract with HRG.
So moved. This is Jerry.
Okay. Second,
Second.
and Dr. Walls, your vote?
Aye.
Okay. Kristen, your vote?
Aye.
Okay. And Rich, yours?
Aye.
And Gary?
Aye.
I'll vote aye as well. Item number 9, resolution number 427. This is something to do with district signature cards at Plumas Bank, US Bank, and local agency investment fund. I'm not sure, Steve or Sean, who wants to speak to this?
I'll take this one as well.
Okay.
Okay, so when we transitioned away from Linda Wagner, we had Linda removed from the signature cards. When I went to the bank and had that done, they brought out the card and said that there were additional signatures on there. One being Michael Hadley, the former administrative assistant, and the late Dana Sandell. I think Plumas Bank said they'd take Dana off because of that situation, but we still need to get the signature card cleaned up. We then waited for the hiring of the new CEO to get them on the card, and so now Sean's here, and what we're putting forth to you is the removal of Michael Hadley and Dana Sandell from signature authority on all of our bank accounts with Plumas Bank, our access to our safe deposit box with Plumas Bank, our account with US Bank and our account with the local agency investment fund. And all of those will now have as their authorized signatories CEO Sean McKenzie, CFO Steve Boleen, and Board Secretary Dr. David Walls. Questions?
The president doesn't have, isn't on the signature card? The president of the board?
You know, historically, we've had the CEO, CFO, and the treasurer, Rich.
Oh,
So Dr. Walls is on there now. Dr. Walls is here in town, either here at the hospital or available every day. So we just chose to keep him on as a signatory. This is certainly something we can edit and change going forward.
I don't have a concern about that, so whatever that's worth.
no, I think it's a good, I'm not suggesting taking Dr. Walls off, but I think the president ought to be on there.
I would agree with that. Can we modify it and approve it as modified? Or will we do this now and add him next month?
Yeah, if it's a big deal, yeah, don't bother, but
Yeah,
usually the
let's
president is on it.
Yeah, I can certainly do that. Let's get this so we can get the card cleaned up. And I'd like to, actually, I'd really like to get Sean on as the signatory because I've been signing checks for 2.5 years, and I'll be really happy to not sign checks anymore. It's just not a great internal control. But we'll go with this and then add Ken next month.
Okay. So can I have a motion to approve the resolution number 427 for signature cards?
So moved, Jerry.
All right, and I have a second?
This is
Second.
Kristen. I'll second.
15 seconds. Okay, Rich, and your vote?
Aye.
Okay, Dr. Walls?
Aye.
Okay, Kristen?
Aye.
And Jerry?
Aye.
And I will vote aye as well. Thank you very much. Moving on to contract approval. This is for the purchase of a Hamilton C3 ventilator for $30,319.24. Sean, Steve?
Yeah, I'll take this one too. Diane Dowden, our respiratory therapy manager, may be on the call, but I'll just run it by. This is a pretty straightforward deal. We currently have one ventilator. Diane refers to it as a traveler. And what this would be a dedicated unit. It also provides for neonatal testing and other functionality that isn't present in the existing machine. Diane says that these are available now, and with the circumstances going on right now, it certainly would be a time to do this. With this and the two BiPAP machines, Diane thinks this is the limit on what the equipment that we could staff. And we will apply this purchase against the COVID funding we've received from the stimulus funding.
Steve, this is Sean. I did receive an inbound question related to the neonatal components of this respirator. I didn't get anything from Ms. Dowden about the need for the neonatal component. Can you help verify that or clarify some of that? Is it just it's an added addition to the respirator?
Yeah, it's.
Don't want to put you on a clinical spot.
No. What Diane said is that there's an end-tidal CO2 monitor and the neonatal software are not on the other event that we purchased.
So we have no capability today at all if that were to present to us.
I couldn't speak to that, but the machine doesn't have the capability from what Diane has represented to me, no.
Okay.
Our current existing machine. I don't know, Dr. Walls, he's probably knows it as well as anyone.
Yeah, I'm not sure what the question is, but I see the problem with the ventilator being the staffing, not the equipment.
So if I can jump in here and refer you to the cover letter, this is a letter that was submitted by Diane Dowden. She notes that they have 2 V60 machines which are capable of invasive ventilation, but not recommended for COVID-19 patients due to the fact that it has an open circuit. So I don't know if somebody else wants to speak to that, but I think that was a little bit of a statement of why there's a need.
Those are I believe those are the BiPAP machines.
Yeah. So it does meet the need, obviously, for COVID. If we have to do an intubation, it meets the need better than what we have today. Certainly the closed system keeps the aerosolization from escaping, if you will. So the only piece was the neonatal component to this. In my opinion, we've got to be prepared for anything that meets the door. And if we have a baby that's coming neonatal that requires a respirator, then we should be able to meet that need. It's really a cost value analysis, in my opinion, but I would certainly be for it.
On
you.
this
What is the position of the medical staff?
Yeah, this is Dr. Cooper. My question is does this ventilator have the capability of putting like a HEPA filter on or an N95 filter, so that if we could use it on a COVID patient and not aerosolize it? I don't see, are we paying extra for the neonatal capacity?
Yes.
We are.
There is, it sounds like maybe we need to get Ms. Dowden, if we can get her to come to the meeting to help describe a couple of things with the neonatal component of this, but also the closed system as it relates to COVID, Dr. Cooper.
Yeah.
Why wasn't the medical staff involved in this?
Good question.
So let me ask, is Ms. Dowden available? Can we jump this for a minute and come back to it if she's available?
Yep.
That's a yes, okay.
Yes.
Why don't we skip until she is available? Steve, I'm assuming you'll let us know when she is.
Yep.
That said, item number 11 takes us to the independent audit for fiscal year 2020. Mr. Tucker from JWT Associates, I'm assuming is here to join us and fill us in.
I am here. Can you guys hear me okay?
I can hear you just fine. Others?
Yes.
Okay. Thank you for joining us. Thank you for your report. I took a look at it earlier. I'm wondering if you can walk us through the
Yeah.
features of that.
I much prefer meeting in person. I'm sure you guys do as well. But this is an interesting time that we're surviving through. I've had to do all of my audits and board reports for the past since March, so 6-7 months via video or telephone conference, and I'm getting used to it. But I still would prefer and like to get back to in person. But we'll do the best we can with the situation that we're dealing with.
Can I interrupt you there? Yeah. I'm sorry. I'm wondering if it's necessary to ask TK to put on the screen for everyone to report or not. I'll leave that to your discretion.
You're talking about the administrator there?
Well,
because I'm just on the phone.
With us? Apparently she's not. I guess my question.
Hi, Ken. This
How-
is TK. I'm actually in the middle of a call with Diane trying to get her connected for you.
Okay, let's let Mr. Tucker jump in. And I just want to ask you again, is it necessary for us to have this on our screen as you walk through it?
No, you should be fine. I mean, if you've got it in front of you, right? You've got
Yes.
the audit presentation, which is like a 4-page summary, and then you've got the actual audit draft, right?
Yes.
Yes.
Okay, so yeah, we can just follow through this. We'll start off with the audit presentation first. If you go to page 1, I'll summarize the financial results here, audit results, and the information that has to be reported to the board, for you to consider to approve the audit, and so we can move forward with issuing it. So first off, you received an unmodified opinion for the year. That's a clean opinion, same as the last few years, and that's what you're always striving for. Second, there were no material weaknesses or significant deficiencies identified relating to the hospital's internal controls, and there were no reportable findings. So through all of our testing, confirmation, reviewing documentation, and going through everything, no issues that had to be brought to the board. There were no audit adjustments, and I've explained the difference between an audit and a late client entry before. Is there anyone that's new and would like me to kind of clarify on that, or do you understand the difference between an audit adjustment and a late client entry?
I'm not sure I understand it.
Okay, so an audit adjustment would be, Steve is all done, he's given me all the information, I'm going through and doing the audit, and I find an error. Something wasn't booked correctly, something didn't follow the right accounting principle, and I have to make the correction. So that's an audit adjustment. That would be what we just talked about before. That would be a reportable finding. That would probably lead to either a material weakness or a significant deficiency, because what that says is through all the internal controls and through all the review and processes at the hospital, they missed something, and it fell to me to find that. So that's an audit adjustment, and you don't want those. A late client entry is we start the audit as early as possible, and there's always a few things that we're waiting on. One of the main ones, as you can see, one of the 2 late client entries is the cost report settlement. The cost report's not due till November. We have to do the preliminary audit. We kind of get the audit about 90% done, and then Steve submits all the financial data to the cost report consultant. They complete the cost report, and then depending on what the cost report ends up being, we could have an adjustment or not. For this year, your cost report adjustment or your cost report settlement was $1.4 million. And so Steve, after discussing this with Steve, management of the hospital decided we're going to book this cost report settlement. We're going to book the $1.4 million receivable, take it into income. And then because they did that, or kind of in the same thing, they also were looking at the COVID supplemental funding they received, and they had recognized $828,000 in COVID funding, and they said we're going to back that out, and we're not going to recognize that COVID funding, and because we don't need it because of the large cost report settlement, and so we'll kind of save that for a rainy day. In other words, we'll push that COVID funding recognition into the next year, or fiscal year 2021. So a late client entry is not an error. It's not something I find. It's just something that happens after the audit started, and these are normal and usual things. Does that make sense?
Yes.
Thank you.
Okay. And the 1.4 income, that was expected because of the drop in volumes this year. Being a critical access hospital, you're cost based. And so when your volumes drop, and they drop pretty significantly for the fiscal year ending 2020, that large settlement was kind of anticipated and expected, that 1.4 million. And then on the last one, there were no difficulties encountered with management performing our audit. There were no disputes or disagreements with management during the course of the audit. Everything went well. I really have to give kudos to Steve and his staff. Like many of my clients, they had to prepare everything electronically for me. We didn't come on site because of the pandemic, obviously. But Steve did a great job of packaging everything up, getting it to me electronically. We still did all the same procedures, all the same audit steps, everything we normally do in the audit. We just did it all electronically and remotely. A lot of emails, a lot of files being, sent back and forth, and phone calls and whatnot. But Steve and his staff really did a good job to make this audit go as smoothly as it did, given the restrictions with the pandemic. So anyway, kudos to Steve and his staff. Any questions on those first 4 items? Those are the items that have to be reported to the board that you need to consider when you're approving the audit. So any questions?
Questions?
Nope.
No.
Okay, well, let me go down below. Let me just touch on a few significant accounting / auditing issues, just to make sure, let you know that we're looking at them, let you know what we found, and if you have any questions, because these can be somewhat technical. You're continuing to participate in the IGT programs. That's the intergovernmental transfer programs. Those have been very beneficial to the hospital over the last few years, and again this year. In the Prime program, you paid out through an intergovernmental transfer of $432,000. You received $864,000, so you made $432,000 on that. Prime's been an ongoing program to expand and enhance, giving medical services in underserved areas, and the hospitals really benefited from that program. The standard IGT program, which is basically a kind of a Medi-Cal supplement and rate range supplement. You paid about $1.2 million, received $4.1 million, so you netted about 2.9. So you had over $3 million net gain on your IGT programs. Those were all booked properly. Steve does a good job of booking those, isolating them so that it's easy for us to find them in our audit and make sure they were done properly, and those were all accounted for properly. And so that's your IGT programs. You should be getting pretty familiar with those terms now that you've been doing it for, 5-6 years now. Board restricted cash. I just want to remind you, a number of years ago, the board restricted $1.1 million in cash. And so when we do the audit, we break that out and put it in that line item that you see that says assets whose use is limited. So when you look at the balance sheet, and I'll get to that in a minute, there's a line item that says assets whose use is limited, and it's $1,125,000. That's basically money that the board has set aside and said, you can't spend this unless you have our specific authorization. The way the cash situation is going at Seneca, the board may I don't want to step on any toes, but the board may want to consider putting some more funds in there, or earmarking or making board designated some additional funds. You're up to $13 million in cash on hand, so it's just something to consider. Then lastly, your COVID-19 supplemental funding. So that all came in, and actually, we audited a significant number of hospitals and clinic operations throughout California and the Western United States. They all did quite well. They actually, I think most of them more than made up for any shortfall in volumes or whatever other issues with the funding that was granted. The hospital had a PPP loan of $1.5 million. That's the payroll protection program. That loan is sitting on the books as a loan right now. You'll see that in the balance sheet, and it's pretty much, a lot of it's in current, but in that long-term liability, you saw that $1.5 million gain in long-term debt. Well, that's the PPP loan. What's going to happen is in the next month or so, with the reporting that Steve's doing, that loan will be forgiven. And during 2021, that'll turn into a grant, and that 1.5 million will come into income. I think everyone understands, has heard quite a bit, understands that's how the PPP loan works. Your other money received were HHS and HRSA grants. Those were grants from the get-go. You got 4.2 million, so you got 5.7 million in COVID funding this year. It was all properly accounted for, and as I said up above in that on that late client entry, you really haven't recognized any of that $4.2 million in the standard grants, and so you still showed a net income of about just under $900,000 for the year. Obviously down a little bit from prior years, but you didn't take any of that any of that in. And so you have that to use as you go forward. As this pandemic continues to stretch on or any other issues happen, you've got that then to bring into income over the next year or so or whatever. So those were kind of the main things we looked at. Other than that, no red flags this year, no other big accounting issues or issues or problems that we saw. Really a good solid financial year, even with COVID, a pretty good solid financial year for the hospital. You guys addressed all the issues, in a timely manner and really handled the kind of the COVID effect quite well. And so, did well. Any questions on those? Any questions on those items right there?
Anyone?
Nope.
Doesn't sound like it.
Now you guys are an easy crowd. The next page, I summarized that, so that's basically everything I need to report for the audit on that first page, on page 1 there. Page 2, I summarized the statement of operations, the income statement, so you can kind of look at it and kind of an easy way see how we done the past 3 years. You can see your volumes were back down to 2018 levels. Actually below 2018 levels by about $500,000. You were at over 20 million last year, around 18 million this year. Other districts, other operating revenue was down as well, and taxes and whatnot. And again, most of that's probably most of that's tied to volumes and whatnot. So it was to be expected. You can see your expenses went down as well. So you managed the again the effect of COVID quite well. Still made $856,000, so a good, strong, good financial year. Your net income margin, of course, with the drop, your net income margin's down. But a couple of things to note, your deductions from revenue were down significantly, which means you're continuing to improve and do a better job of with your revenue cycle management. And all the testing we do a lot of testing and work on the revenue cycle, which is the billing and the collection of your patient AR. And the hospital's really done a good job, and this year is no exception. They really did a good job and you have you've done a good job of bringing in and billing everything and collecting what you bill. Bad debt still stays about the same, about 4 or 5%, which is pretty much industry standard for a hospital like yours. And your a couple of your expenses that we always look at, labor and benefits as a percent of expenses or as a percent of net patient revenue, stayed consistent, stayed right where we expected it, and same with supplies. So again, even with COVID, a pretty strong year, and the hospital, like I said, the hospital managed it well. The next page, page 3, is the balance sheet for. Oh yeah, go ahead.
I'm sorry. This is Jerry. I have a question.
Yeah.
So you were talking about our revenue cycle, and in our audit, it shows days in net AR looking pretty good. But then, when we look at our financials on a monthly basis and we're looking at our gross account receivable, that's much higher. So can you maybe speak to that?
Well, sure. So healthcare is a really unique industry in that you rarely collect what you bill. So your AR, when you bill at your charge masters, or so your full price, and then everybody other than maybe some private payers, which there are less and less of nowadays, everyone's going to pay what's called a contractual amount. So you're going to bill. Let's just take an example, Medi-Cal. You're going to bill Medi-Cal $1,000 for some operation or some healthcare service. They're going to pay you $300. The difference, that $700 difference, is the contractual. And so even though your gross, it can fluctuate and go up or down, and it's not uncommon to have it like that. But the key is that Steve does a good job of estimating and then booking the estimated contractual allowance, or the amount we won't receive, or the hospital won't receive, and any bad debt component of that as well. So when you see the gross, and you can look at the gross, and there's some things you can use it for to do analysis, but what's more important for the hospital is that net receivable number. And done a good job with your managing your net receivables. I was looking down here. Your net AR was 1.5 million last year. It's down to 1.1 million this year, and so that's the key number. And the difference between gross and net is, again, any estimated contractual that the payers you're dealing with, Medicare, Medi-Cal, insurance companies, have contracted to not pay because they're going to pay the lesser amount. Did that help you out?
Yes and no. I understand as it relates to the actual dollar amounts, but I'm trying to understand how the days are different, or so different.
Well, I didn't calculate. I don't really look at gross days. Let me pull that up real quick. I should have. I probably have that.
Well,
here.
our most recent one for this month shows gross account receivable days 60.3, and we're targeting 45 to 55, and so that's where my confusion lies.
Right. To get your gross days down. That's a good task. The problem with a lot of healthcare AR is you get a lot of stuff in there that doesn't get cleaned out in a timely basis, and so again, it's good to monitor that. The net number is much more important. The difference is that Steve takes the hospital takes a conservative approach. And so the difference in the days is because, I have it here. So your net days are, in the 30 range, or what is it? Net days, 27 days, and your gross days are pushing 60. Is that what you're looking at?
Yes, that's right.
So the difference is, especially when your volumes are going down, you have to understand that gross AR, there's a lot of older stuff in there that collection companies, you're hesitant to write it off, a lot of it right off, because you're always kind of holding out hope you can rework it or submit it or whatever and still get paid something on it. So you've got a lot of stuff that sits in that gross AR that could be 6 months, a year old or more. And especially when you have declining revenue like this year, it's going to really drive up the days in gross AR. It doesn't surprise me you're at 60 days, and that's really not that bad. The lower, closer to 20 some odd days in AR, 22 or whatever it was this year. That's the number we focus more on, and that's because, again, now think in your mind, we've cleaned out all of the old stuff. We've added in our estimates of what we're not going to receive, and so now we're really looking at net AR versus net revenue. Net versus net, and that gives you more of a true picture of what you really have in AR, the days you have in AR, because it eliminates a lot of that old stuff that may have accumulated in there that you're still trying to work, but it kind of skews the gross calculation.
Okay, that makes sense. Thank you very much for that.
Okay. All right, and then so now let's see, page 3, the balance sheet. So if you look at the balance sheet, we just talked about some of those things. The first thing that sticks out is look at your cash and board designated. You were strong last year. You're a lot stronger this year. An increase of almost $6 million in cash, up to $14 million, $14.3 million in cash and board designated. Patient AR went down, like we talked about that. Other receivables, the big jump there was that settlement we talked about, the Medicare settlement of over $1 million. Small addition to property and equipment. Everything else looks pretty standard. And again, as I said before, that big increase in long-term debt, $1.5 million in PPP loan, that's going to get, based on all the information I've seen in my discussions with Steve, that's going to get forgiven. So that'll flow through income this next year. And of course, with the PPP loan and everything, the current ratio obviously is going to go down. So you got an extra $1.5 million in debt that's sitting there for a few months, and your debt service coverage and everything else is going to go down. But you look at cash on hand. You have 304 days cash on hand. I don't know how long most of you have been, associated with Seneca, but I know some of you are old timers and been associated with Seneca. 300, that was just a dream several years ago. 304 days cash on hand. I remember the days at Seneca when you had, you were almost counting the hours of cash on hand, but you had maybe 10 to 20 days is all. And so really strong position. Days in the R continue to go down, and that's a good, and your average pay period stays about right where it should be, right around just a little over 30 days. And some of that's timing wise when you pay your AP, but that's a good strong number. So overall, the balance sheet was really strengthened, and you weathered the year, and now it's hopefully you're doing the same thing. What little I've seen, it looks like 2021 is going the same way, and you're just weathering this pandemic quite nicely. That last page is just some comps, the things I already talked about. We put some comps. We take some of the analysis we did from the last 2 years. We do a peer hospital average. Those are hospitals we actually audit. Those are June 30, 2020 numbers. We pick 3 or 4 similar hospitals, critical access, similar payer mixes, similar size, and we average them to give you an idea of how you're doing against other successful hospitals in California. And you can see you're right in line with pretty much everyone else. And the benchmarks are our own benchmarks that we look at kind of a minimum of where you need to be to have a successful hospital and be able to continue to do what you're doing and provide services at the level you want to. And so anyway, so that's what you have. Good year. Thanks again to Steve and his staff. Any last questions?
Hearing none, thank you, Mr. Tucker. It was an interesting report, and it's always good to hear something positive. Thanks to Steve for all his expertise in getting that information to you as well. Nice work.
And I greatly appreciate the thoroughness of it, and thank you for your presentation.
Okay. You guys voting on this today, hopefully?
Yes.
Okay. With that said, we have our annual audit report. And so we need to approve that. Can I have a motion?
This is Jerry, so moved.
And can I have a second?
I'll second it. This is Dr. Walls.
Okay. Kristen?
Aye.
Aye. Rich?
Aye.
Thank you very much. Dr. Walls
Aye.
and Jerry,
Aye.
and I will vote aye as well. Again, thank you, Mr. Tucker.
Great.
Okay.
Thank you much. Steve, I'll be in touch with you to get the final issued, and we'll get this taken care of.
All right. Thank you, Gerald. Take care.
Thank you. Have a good day. Bye-bye.
Would like to go back to item number 9 on the agenda.
Yeah, hi, this is Steve. I think we're going to pull this off the agenda and have a little more detailed discussion, including with medical staff, and see if
I'm sorry,
we can come up with a solution that.
Item 9, Steve, I'm sorry. It was item 10 we're talking about.
Yeah, can you all hear me?
Yeah. I misspoke. I said item 9. I meant to say item 10.
Okay. Yeah, so let's just do that. We'll take this one back and we'll have a larger discussion and come up with a recommendation that we feel that everyone can be comfortable with.
Just for 10, Steve?
Yeah, the ventilator purchase.
Oh, I'm here, Steve, in case, can you hear me? This is Diane.
Yeah.
Yeah, I can hear you, Diane. So
Okay.
we don't want to put, it was my error. I don't want to put Dr. Walls or Dr. Cooper on the spot, specifically Dr. Walls having to vote as a board member about something.
Okay.
We can take it to medical staff next week and come up with a solution,
Okay.
including whether or not we want to retain the neonatal capability and all
yeah.
that.
Yeah, and the only reason that neonatal is, just so they know, is because we have no capability. If we do have to intubate an infant, that's why that is on there. We have no capabilities other than that.
Okay, and
Steve,
we will
Steve, I have
we
one
will discuss that.
concern. I have a little bit of a concern here. It's, if we put this over, this would come back on our, it goes to urgency. This would go to our December 31st meeting for any action. How much of a concern is that? The timeliness of it?
Well, Ken, I might suggest that we could hold a special meeting just to cover this topic in the interim.
Okay.
I don't know if Steve wants to answer regardless, but that would be my suggestion.
Well, we would appreciate that, but that'll again be something that we can bring out of medical staff next week. If there's a sense of urgency, we will certainly take you up on your kind offer to meet again.
Okay.
Well, I guess speaking for Sean.
Okay, Steve, it's okay. You're spot on.
Okay, thank you.
That takes us down to our information items agenda piece. And so we have here, our first item is HRG. Is that you, Steve, or Sean?
That'll be me. So HRG continues to plug along, and I did hear the discussion, Jerry, about the revenue cycle, and I think that's one of the funny things about when people look at days by net and by gross. And I've always tried to go by gross. To me, it means more to me, and so maybe it does not present all of the picture or presents it from a different perspective. But I'm going to continue to do that. But one comment I'd like to make about the our net revenue percentage going up, and I think you guys saw that when we were doing the impact of COVID and projecting out. It wasn't really clear to me. It seemed like an element was like a payer mix based upon the way that the utilization of the hospital was affected by COVID, that somehow we were having less adjustments. And I just prepared the uncompensated care report for Medi-Cal managed care, and our ER utilization on Medi-Cal managed care is way down, and the adjustment percentage on that is very, very high. And so again, it's kind of one of these weird, it's like the reverse of an unintended consequences and unintended benefit that a lot of Medi-Cal beneficiaries, because they don't have a direct patient liability for coming to the hospital, they may have a share of cost, that there's no disincentive for them not to utilize the hospital in any way that they see fit. And we can't turn them away from an emergency visit until the provider, the caregivers, clinicians do their assessment of the patient. And usually once you do that, you're already into a pretty good sized bill. So anyway, that was just kind of interesting that came out when we did when I just did that report. So anyway, but HRG, we're continuing to work with them, and we didn't make the progress, continued progress that we had made from July to August, but we're just going to stay on it with them, and I think we will get there. Any questions about what the numbers represent or concerns about where they're at? And Jerry, to your comment, I know we talk about 45, that's a best practices. That would be a phenomenal occurrence. I know we've gotten close at times, but haven't been able to sustain it. It's one of those things, to get to 45 and stay there, everything has to be working all the time, and that's an immense challenge.
Yeah, and I appreciate that, Steve. I just wanted to kind of understand, where the audit piece fit versus, our regular reporting, just because I was trying to understand it from where HRG fit in and all of that. Will you remind me, did they ever assign us a specific person to work with?
Well, we have a team that works with us, and there's a hierarchy within the team.
Okay.
And a pretty high-level person, like a director within the organization, regularly participates on our weekly calls and engages on specific issues. And I think that's kind of where our sense of hope is, because those are the folks that have to manage their staff effectively, and that's where we've fallen down in the past a little bit.
Got it.
You said a
Thank you.
high-level manager, Steve. Is that a consistent person or just, does it
Well,
rotate?
yeah, we burned through a few, but the team that we have right now, we've had for some time, less than a year, but probably approximating a year, and we've worked with them and seem to work with them well, both myself and our revenue cycle person here, Sarah.
Okay.
Great.
Additional questions for Steve? Well, thank you very much, Steve. Appreciate your work.
Thank you,
Okay,
Steve.
thank you, guys.
Okay. It takes us to item number 13. I don't think there's any motion here or activity related to the Strategic Planning Committee. Am I mistaken?
Nothing on this
The only
part
thing,
yet. Go ahead, Steve.
yeah, the only thing we have that's been on there in the past is that we have Lance Monath has connected with Collins, Neil Fisher, and he seems to think that we'll open an escrow on the property next week or this month. So that's it.
Okay, well, thank you. That's good news. Well, Sean, good to have you. First CEO report. We're looking forward to it.
Well, good. Hopefully I don't
Yeah.
flub. Yeah, great. No, I just want to start off by thanking the staff and the community. It has been a great 2.5 weeks. The community's welcomed my wife and I with open arms. The staff has just been absolutely forthcoming and just great and welcomed me in. And Steve's been working to get my feet wet and expose me to everything that he's been going on, and he's done a great job. And obviously through the audit, you could see that he has been really watching the farm, really doing a good job. So Steve, awesome, thank you. I guess we should start off with the subject of the year, and that's with my COVID report. It has been an interesting week or so. I'll start off the good part. Just before Thanksgiving, we initiated a preemptive strike, if you will. We wanted to bracket the Thanksgiving holiday by providing a free COVID testing through the hospital. We had great turnout. 79 people came in and got tested. That was a good turnout, and the philosophy and the rationale behind that was, let's bracket the two holidays. Before you take off, let's get you tested, and as you come back into the community, let's get you tested. So we have another one coming up, and it's available on the website. We're also going to bracket the Christmas holiday as well. So that's good. Just trying to keep a proactive approach to what's going on in the COVID. We are obviously in the middle of a surge, and the rumor on the street is that we're going to have a spike on the surge from the Thanksgiving. That is the perspective of not just this community, but other communities throughout the state. I can tell you that we are in the surge. And part of that, we should just talk about, there's been a press release that went out today to the community. For 9 months, we've done a great job of mitigating the impact to Seneca Healthcare, in the sense that we have really done great jobs in just keeping the ingress and egress and making sure that that we're protecting our residents in our hospital from COVID, regardless of any surge activity. We will say that we have had an exposure, and we are working diligently. The team is working countless hours to mitigate the impact of our surge internally. We do have some active cases in the facility. There's a sequestering going on. There's a mitigation strategy to keep other parts of the hospital from infection. So without getting into a great deal of detail, I can tell you that we have had an exposure internally. It's being mitigated and managed very effectively by all the staff, including our medical staff. So I want to thank them for that. And it's an ongoing thing. We're working diligently to protect our community, but that's out there. And I just want to make sure that the board and the community understands that we are working very hard to pull this together and stop this. So that's anything. I could stop there for questions or just move through my report and take questions at the end if you'd like.
Let's see if there's any questions there first, Sean. Questions? Okay. I guess it's just too early to tell when we would expect this, because we have the holiday season coming up to peak and to start resolving itself. Too early to make any predictions?
Certainly. I get no predictions from anybody in the public sector. from any of the public health departments or anything. Just that we are in the middle of a surge, and with the movement in and out, family movement to address the holidays, we do expect that regardless of the pandemic issue, we are going to have movement and we will see a spike. That's the ultimate thought process.
Yeah.
So we're gearing up for it.
Thank you.
Sure.
Anyone else? All right, let's move on, Steve.
Okay.
Sorry.
So in addressing the surge, we have our incident command or our huddle every morning, and it's reported out that the higher levels of care or the transfers out are being impacted as well through the surge, not just in this county, but elsewhere. Our staff is diligently, obviously, working on making sure that we have transference capability for higher levels of care should somebody present that needs to be moved to a higher level of care. So that's a constant, ever evolving thing where we're just staying on top of it and working with our partners out there in the Valley and such in establishing that relationship on a very proactive basis. Once again, we talked about sequestering. We've been working through multiple scenarios through this COVID surge about what could happen and how we would manage each, including the sequestration of different parts of our hospital. You'll notice that if you come out to the facility, you'll notice that we now have a temporary building outside the emergency room that's going to be used as sort of an anti-space as our patients are presenting to us so that we can assess their COVID symptoms and their positive, minus, or negative aspect to see and to bring them into the main hospital. So we're working to keep things sequestered on the outside and not bring things in, which creates a possible infection zone within the emergency department. So that's another thing we've done. We do have delivery of that. It is in use today, and it is constantly evolving as to how we're going to use that anteroom. It is a temporary building, and it was also purchased under the COVID money. So it's something that's going to help us be able to control any kind of surge that we get. We are working with medical staff. Dr. Cooper mentioned it earlier, working directly with medical staff around therapeutic pathways. These are pathways that have been offered up by a lot of our partners, our healthcare partners out there in the world, some of the larger IDNs or integrated delivery networks like Adventist and Stanford and some of our locals, helping us understand peer-reviewed pathways. So our medical staff is reviewing all these things and developing pathways internally. We have dedicated to our medical staff that we are going to be seeking things that we do not have. If it's in the pathway and we do not have it, we will be purchasing that so that we have it available should we need to treat internally and move that pathway forward for patients. So it's great getting a lot of movement from our medical staff, and I do appreciate the medical staff for taking a look at it and trying to define it for us. PPE, our PPE is greater than 30 days. We've done a great job of looking at other supply chain avenues. If we're running out, the county has helped us out, but we are really in good position for our PPE locally for our staff and for our visitors. So we're pleased with that. We have completed our enrollment in the COVID ready provider enrollment for COVID ready vaccines. So we have completed that application today. That would put us in line for the receipt of the vaccine, the Pfizer vaccine that's expected to be released, I guess, within 10 or so days. We are setting up the logistics associated with the requirements for storage and delivery and reporting for all of, sorry, am I still there? Okay.
Yeah, you're here, Sean. Go
Okay.
ahead.
Yeah,
Take a little pause.
my computer's acting strangely. So we are ready for that. The county will be doing the distribution of the vaccine out. So we're taking inventory as to how many numbers we need. In initial phase one, it's going to be a lot of our caregivers and our residents. So expect that you'll get more reporting up on the phase two, phase three as more vaccines become available, not only from Pfizer, but from other pharma companies that are developing these therapeutics and these vaccines. So that's really good news. We're ready to go on that. I talked about the pre-holiday, post-holiday bracketing of our COVID testing. That is coming up. We'll get some news out for everybody. COVID funding, we talked about that. So with all that, I'm just going to kind of pause and not flicker. I think most of my computer's flickering. So that must look great. This is like a slideshow. I'm going to pause for any questions. I am going to ask the board for a sort of a standing approval, a motion for a standing approval to purchase as necessary up to a certain dollar amount, anything that we require to address any kind of COVID surge internally without having to come to the board at a next board meeting or have a special meeting. I would like to have some sort of a bracket or a ceiling around our spending capabilities ad hoc as we need it. I mean, we could certainly address the board individually or put it out there, but I would like to request that the board consider granting us the approval for purchasing as needed.
And Sean, I'm assuming that that would have to be at our next meeting or at a special meeting. Sounds more like a special meeting as it's not agendized today.
But Ken?
Yeah.
Don't we already have a limit that applies to the CEO
We
purchasing?
do.
Yeah.
We do. I don't recall off the top what that amount is. Does anyone remember?
I think it's 25,000
Yeah, it's 25.
25? Okay.
for single purchase, right, Steve?
Say that again, Jerry?
Sorry, for a single purchase, right? Is this 25,000?
Well, yeah. If it's not going to cause an expense of over $25,000 in a 12-month period, then the authority's there to purchase it.
Okay, that's good to know. Thank you. I wasn't aware of that, but that's good. And we're going to need that to be able to make some operational decisions on the fly. So thank you.
Okay, well, you may want to consider and let me know if you feel a need to expand on that amount, and if we need to schedule that at a regular scheduled, special board meeting.
Okay, I'll work with Steve to see if that 25,000 cap is working for us on availability for operational needs. Appreciate it. Okay.
Hey, Sean?
Yeah.
Can I ask a question? This is Dr. Walls. With regard to the Pfizer vaccine, what is the status of refrigeration requirements?
That's good. So we have to have what they call super cool. This requires super cool refrigeration. The county has purchased super cool and is able to store the number of vaccines that they're the allocation to them. What they're going to do, and the logistics behind this is that they're going to distribute it to us, and we can keep it in a regular refrigerator that is monitored for up to 5 days. So it requires logistically that window. We have to be able to vaccinate within that window. Specifically to the Pfizer. We can also use dry ice, and we do have availability for dry ice. That also meets the needs for super cool, but we're hoping that the logistics around our vaccination period, our time period, meets the 5-day window so that we can just refrigerate it normally.
Thank you.
You bet.
Sean,
Okay.
this is Jerry. I have a question also.
Hi, Jerry.
So where it relates to the modular building,
Yeah.
I understand we're testing folks and screening there before they're entering into the emergency department. Did I hear that correctly?
That is the
That's-
initial, that was the initial reason for it, and it's evolving to Jerry. So we're looking at different use cases for it. We're staffing it and supplying it differently. Royce is kind of leading that charge to figure out the use for that building, but yes.
Okay. The reason I'm asking is because I understand trying to, keep COVID out of the emergency department, but if you have someone who presents who does have COVID but needs emergency department care,
Yeah.
what is our plan there?
No delay. No delay. It's certainly, that we're not going to put our sequestration principles in place of patient need at all. But it is, we will obviously attend to our patients as needed. And, if we're presented with somebody who needs immediate attention, that's just the way it's going to be, and we'll figure it out. We'll work through it.
Okay, thank you.
Question about the Regeneron or whatever we may be acquiring it as a therapeutic. Is there a cost for that?
There is certainly, there's a cost to these therapeutics. Some of them are still being presented from a government perspective for free, but they're falling off that. So as these therapeutics come out, there's a period of free, but free also means supply chain issues, generally what we found. So like the remdesivir for a period of time was being provided, but now it's a cost of roughly, I think, $3,600 a dose for a 5-day therapeutic dose. So we're going to try to take advantage of anything that we can get free, obviously, but the COVID money that was spoken to by Steve certainly is going to cover the cost for these therapeutics should we need them.
Yeah,
Availability is the biggest issue, though, really.
Sean, what I'm getting at is giving you authorization
Mhm.
to go ahead and, as we talked at the treasurers meeting, I know Ken has said it isn't on our agenda, but I'd like to see you be authorized to to go and make these acquisitions, maybe by getting one of the board executives to approve it without having to have an official board meeting. I don't want to see us have to be delayed if we need to do something quickly, take care of the community.
Certainly removing any self-induced delays would be nice to not have in front of us. I mean, we're already going to be seeking delays or seeing delays from distribution. We're not, quite frankly, on the top of the hit parade on this one. There's a lot of COVID sites that are being spun up throughout California and other places that are, I'm sure, going to get priority around some of these therapeutics. We will fight for them, obviously, but yeah, if you want to provide an avenue so that if it's presented to us, we don't meet our own roadblock, that would be terrific.
And I'm just not sure the mechanics of that, Rich. I support the notion. We should probably research the mechanics of that. I'm available as soon as possible for a special meeting if need be.
Okay. We're going to be working with the medical staff to just stay up on the therapeutics. They're going to be coming fast and furious. I do believe that there's a lot of attention being paid to these. So as different pathways and therapeutic pathways pop up, we will make sure that the board members and the medical staff are aware of them. Certainly part of that dialogue is going to be the availability and the ability to distribute. Unfortunately, we're looking at the working end of the vaccine. I think it's telling that the Great Britain started vaccinating, I believe, today, and they have an equivalent to our FDA. So if we want to just take out the thrash that's happening around the community or around the country related to any kind of politics, this was an independent study done by the FDA of Great Britain, and they found it to be the efficacy of the vaccine to be very good, and they've started ahead of us. So I'm hoping that people jump on the bandwagon and feel comfortable with this vaccine. I certainly am. So I want to really push the community to consider this vaccine, as I think it's going to it's going to push us over the top of the hill that we really need for the community.
Yeah. I heard 95% effective.
Very high efficacy. Yep.
Yeah.
Very good. And the other ones coming out are equally, in my understanding, everything I've been reading. So we'll be staying with our medical staff to make sure that they take a medical look at this, a scientific look at this, instead of just the administration making decisions. They're going to be involved in every decision made.
Okay.
Okay.
All right.
Great. Auxiliary, I had a terrific meeting with our auxiliary, Nancy Foote and Maggie Fleming last week, or the week that I came. They're excited to get their cadence back. We're excited to have them back. This COVID thing's been a little disruptive, obviously, but had a great meeting. They are a great partner for us, both within the hospital and within the community. So I'm really looking forward to being able to reestablish a cadence with our auxiliary. We're hoping for January, but I'll keep you up to date. But I had a great meeting, and they are so engaged in this community. They're super engaged in this facility, and they're great partners. So I just wanted to bring that to the board to let you know that as soon as we can, as soon as we're free to go, we're off and running again. So it's exciting to work with them once again. I'm looking forward to some face-to-face meetings. Information technology, I want to bring this to the board, and we'll probably be bringing to the board a proposal or two in the future. You know, we have to understand that we are a healthcare provider, and information technology, as quickly as it moves, as fast as it moves, specifically in the areas of infrastructure and security. Infrastructure meaning our local area network, our servers, really the freeway that all of our applications, our clinical and business applications run on, is constantly changing. So we're looking to, it was TK brought to my attention the opportunity of maybe looking at a help desk or a service desk for questions related to our infrastructure. We will still manage a lot of our applications along with our vendor partners, but our infrastructure seems to be one that needs some attention. It's going to improve the speed and delivery of these applications to the greatest degree possible, also the security and our directory. So what I'm going to be doing is getting some from information technology companies that deal specifically in infrastructure, with one specifically that works in the banking industry, so security is very important to them. I'm going to be presenting to the board very soon a full assessment and optimization effort and proposal coming forward, which includes the assessment catalog of all of our network devices. For those who speak IT, I do a little bit, including AE titles, IP addresses, locations, operating systems. So we understand what our environment looks like from an infrastructure perspective. Until we can do that, until we can optimize our infrastructure, it's really difficult to optimize our application layer. our applications to our doctors, to our clinicians. So we're going to undergo a big assessment with a very detailed optimization strategy and standardization strategy. At least that's what I'd like to do. And of course, we're going to bring part of this is going to be the advantage of a help desk support in our infrastructure. So as we develop more and more digital capabilities, it's running on a good backbone, a solid backbone. Our informatics team, their focus really should be on direct patient experience or patient and physician experience as it relates to our electronic health record and optimizing our electronic health record, optimizing some of our clinical applications. That's really informatics, as well as starting to drive data out of those systems. Informatics is about analytics. It's about data that we can use to improve quality, improve turnaround, and really structure our operations in a way that optimizes internally. So I just want to put that out there. If there are any questions about that, this is a big takeaway, a big to do, but most definitely needed based upon my assessment, at least my initial assessment. Thoughts?
Questions to the board?
I'm just interested to see what comes out of it.
We'll report.
Okay.
Rich, anything?
No, other than what I suggested, you make contact with Jim, who did some of the network assessment many years ago.
Yep. Thank you for that. We'll follow up on that. Okay. I want to report on our airport. So Rogers Field is getting a precision instrument approach. We are big proponents at the hospital of this because it's really going to improve our ability to life flight to higher levels of care, our community, our patients in our community. Right now, the situation is that we have a beautiful airport with a long runway, but when we have weather or low ceilings or any kind of thing that is going to hold back our ability to transport through an air carrier, they can't get in. They simply can't get in, and they have requirements based upon what their agreement is with the FAA and such to come into. They have what they call minimums. The instrument approach is going to really provide us an incredible opportunity to bring these carriers for medevac into the airport with very low weather conditions. In fact, for you pilots out there, it's down to they can fly as low as 247 feet over the field. If they don't see the field at that point, they have to go around. So it's super low. That has been approved. It's moving through the FAA right now. It has to do an environmental impact report, not like we normally know. It's just an environmental specialist from the FAA that is assigned by the FAA has to take a look at kind of any kind of environmental impact of this type of procedure. The good thing is that several letters have come in. We issued a letter of support. Thank you to the board for doing that. But so has the air carriers, EMS, the Forest Service. So they've received a lot of support from the basin and the community. And the FAA takes that very seriously when they're looking at a community like this and the advantage that this would provide us. They usually push this thing through pretty quickly. So I'll continually update the board of directors and the community. But I can tell you that the flight validation has been completed. So the FAA actually did fly the approach and they've approved it. So we're marching down the path quite nicely. This is going to be a huge advantage to our ability to get our patients out in inclement weather through aircraft and helicopters. So I'm excited about that. Any questions on that?
Other than thank you for mentioning that. I think you mentioned that back in your interview, and it's nice to see it coming to fruition.
Yep, it's going to be, I think it's going to be a big advantage. So a couple more things. So just move quickly through. I've been meeting with our Supervisor Thrall, about our need to improve our wide area network infrastructure. Obviously, those who live in the basin understand that our internet is, let's say, finicky sometimes. I'll just use that word, finicky. And we simply can't have that. In order to cast forward the strategy for this organization using digital healthcare and the ability to create a continuity of care using technology, which is what we really need to do, especially for rural healthcare, we must have a backbone in the basin that is substantial enough to not cause delay, create delay, or, if you will, gray out. So I'm going to be working, I would like the board, and I'm certainly going to act as an advocate for our Supervisor Thrall in any meetings that she needs us in or me in to advocate on behalf of not only Frontier's activities, our providers, but any other provider that's looking to come in and do work in the basin. we really do need what they call a dark fiber or a gig connection for our wide area network in order to manifest the types of things we need to create an incredible continuity of care. I mean, all the way to the point of looking at wearable devices. I mean, there's all kinds of things we can talk about for healthcare, wearable devices and what they call connected health, to really ease our community's concerns and get ahead of any kind of disease processes. It's really kind of a proactive approach. So we'll be working diligently on that. I appreciate Supervisor Thrall's willingness to drive in there and make this stuff happen. So looking forward to helping her out, and I could certainly use the support from the board if we need it.
And
Sean, just a question related to that. What is considered wide area for our purposes?
Anything outside, we consider it anything outside our buildings, anything outside our buildings. So we run on a local area network, a LAN, and it's gig ready, according to TK, and I believe that's the case, but we're certainly going to find out. Wide area network is being able to provide an internet experience or a network experience over a wide area. And it can be, wide area networks can be 10 miles, 20 miles, 50 miles. It's links that provide us this connectivity back to with high speed. So
That's
wide area
kind of what I'm getting to, is there's just pockets, in our basin area where internet access is horrible.
Yeah, and the wide area network will incorporate, I mean, we're going to be pushing for not only just the Lake Elsinore Basin, but the Indian Valley area down through Canyon Dam, those types of places. So we're looking for a better experience overall.
Yeah,
in general. Our constituents at PDH and Eastern have good internet, and it does make a difference in the way they're able to address their healthcare needs. And
Yeah,
I think it's time for us to be
much needed. So good.
Yep, so we're going to be
Sean,
pushing that. Yeah.
Might I suggest that this is actually an issue that's even beyond healthcare, because the
Yes.
school district and the kids, especially the ones in Greenville and Indian Valley, they don't have very good internet. It's even worse than we have it here. And so it might be prudent to get the school district board on board with this as well. That would give a little more strength to the position.
Completely agree. I'm just from the perspective of our healthcare system, we'll be in there. But I do agree with you. I think that we will build a critical mass with all those that would be affected, positively affected by this effort. So Supervisor Thrall, I'm sure she was going to get a ton of support for this. I just want to add our support 100%. So I'll be in there fighting for it. Okay. Any other questions? Last one I'll start with is our pharmaceutical contract. Our Cardinal pharmaceutical contract is coming up. Contract is ending here soon, so we're looking at a renewal. Seneca Hospital has an advantage of being part of what we call the Premier Affiliation Program. So Premier is a group purchasing organization. It's a large group purchasing organization that uses the strength of large delivery networks, large systems to drive down pricing on many things, from equipment to pharmaceuticals, just lots of stuff. We've been part of the affiliate program. So when these large IDNs come together and drive prices down, we benefit from that by being part of the affiliate program. I was notified that the Premier GPO that we fall under has even a tighter layer, or what we call a more sophisticated layer of cost reduction called Surpass. And there's probably 10 or 12 big delivery networks throughout the country that are part of the Surpass program. Surpass has changed horses. They have voted to move the pharmaceutical contract through Premier Surpass into AmerisourceBergen. So we have two choices coming into our contracts. We can either get on the train, the Surpass train, and see realization of what I hope is a significant cost reduction in our pharmaceuticals by getting with AmerisourceBergen and the Surpass. The issue is that it has a high degree of compliance. So if you're on, you can't get off the train. In other words, you can't sway too far off of the contract because the compliance piece of this is pretty tight. I have met some of the other affiliates or talked to some of the other affiliates, and they are working with Cardinal directly. Cardinal is going to extend a Premier pricing structure so they don't lose everybody. So that decision will be coming. We're going to be doing analysis. I'll be presenting to Steve as an analysis about our cost savings during these pharmaceuticals, but I want you to be aware of the fact that it's changing a little bit and that Cardinal may not be the direction we'll go, depending upon how well we can see the financial gain. So that's all I have for today. I'll take any questions. And
Sean, I missed something here, modular building lease?
that was actually discussed in my COVID report.
Okay, thank you.
So yeah, that's the modular building we're talking about.
Very good. Questions for Sean? Hearing none. Thank you so much, Sean.
Thank you. Great.
Thank you, Sean.
So we had a report submitted by Jim Kooiman and another one from Dave Monday. Wondering if board members have had a chance to look at those and if there are questions related to those reports. I know Jim's on the line, or he was.
I'm here.
Questions?
It looked good to me.
The question that I have, Ken, is are we getting adequate amount of reagents for the lab testing for the COVID?
And I'm assuming that question is directed to
Dave.
Dave.
Is he here?
If Dave's not on, I did have a conversation, or at least email exchange with Dave today, and it looks as though we are not in jeopardy with our reagents. He feels like we're in good shape. Dave, if you're on, please add to that, but that was a conversation we had earlier today.
Okay.
Related to this report provided, he talks about 21 respiratory pathogens, and we're live and in-house with the system, I guess. Excuse my ignorance here, but this is mentioning COVID-2, not COVID-19.
What? Say that again, Ken?
I'm just looking at the report here, the laboratory manager's report, and I forgive my ignorance. This does or does not test for COVID-19?
It does.
It does.
Yeah.
And what's the time frame for getting the test results?
Well, I'm not sure, but it's rapid. I know that.
My understanding is in-house PCR testing is 2 hours.
Yeah, sounds about right.
That was my question. Yeah, thank you. Were there any questions for Jim Kooiman? Well, hearing none, let's move on. Items to be added to next month's agenda.
I don't know if it's next month's agenda, but I'd like us to discuss the giving authorization to the CEO for, emergency purchase relating to COVID.
Okay, well, let's get it on the agenda, knowing that we may have a special meeting in advance of that. Okay.
Thank you.
Also have the respirator contract, right?
Respirator contract. Okay, that said, I'm going to suggest we take a 5-minute break and then we'll go into our closed session. That would give TK an opportunity to clear the room. I'd like to have a few minutes with just the board members and then invite Sean and potentially Steve and Jim back in when we complete our discussion. So that said, if we can come back at 4:35.
Okay.
All right, and give TK, Jerry, can you notify TK we're ready to have the room vacated?
Absolutely.
Oh, I'm here, Ken. I'm going to go ahead and pause the recording now and put everybody in the waiting room.
Okay, thank you.
Thanks, TK.
Thank you. And we are now recording.
Okay. Thanks for those of you who waited. The board has adjourned the closed session and we'll now move back into our open session. I want to report that there was no action taken by the board in the closed session, and that our next meeting date will be December 31st. No doubt a virtual meeting again. So with that said, Open session is now adjourned.
Thank you.
Thanks, everybody.
Thank you, everyone.
Thank you.
Thank you all.